I invite Dr. Divya Balakrishnan ma'am to deliver her talk on cause of diagnostic confusion.
Good morning, everyone. At the outset, I would like to thank Divya Alex and KSOS for giving me this opportunity. So, my topic is posterior scleritis, a diagnostic dilemma. Posterior scleritis, as you know, is a very rare entity, but it is potentially sight-threatening uveitis, which affects the posterior segment of the eye. And it has got a female preponderance, which affect all age groups. Why is it important to diagnose this? Because this, if we diagnose early and treat, it may prevent the potential severe complications which this can lead to. So it's actually inflammation of the sclera posterior to the ora serrata, and there may be associated inflammation of the choroid and the retina. So it occurs either because of a scleral vasculitis which causes inflammation of the sclera, or maybe because of the autoimmune reaction against the scleral collagen or glycosaminoglycans. So posterior scleritis can be of two types, which is nodular posterior scleritis, or it may be diffuse. The diffuse variety is most common. And when you see a case of posterior scleritis, always you should look for a systemic association. 30 to 50% of the patients can have a systemic association. So that is the important aspect to diagnose this entity. So the etiology, it could be because of immune mediated or it could be infective. So immune mediated usual entities which we come across are rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, or secondary to vasculitis like polyarthritis nodosa, vaginous granulomatosis, or Behçet's disease. Infective, the most common being tubercular or syphilitic entities, or other viral entities like herpes zoster or herpes simplex can also present with posterior scleritis. The patient usually present with a history of pain, and usually early morning dull, boring pain, and pain may be on ocular movements also, and they may present with defective vision. They can have presentation of mild proptosis and congestion. On examination, you will see there will be a scleral congestion, especially more so in the diffuse variety. In the posterior scleritis, you should raise the lid and look for the congestion. And anterior segment, they can have an shallow anterior chamber, especially when these patients are associated with a peripheral choroidal detachment. They can cause a secondary angle closure. They may present with acute angle closure like kind of a picture. So it's very important to differentiate acute angle closure and don't do PI in all these patients. So look for the posterior segment also before you diagnose it. And because I told that there is association of systemic diseases, always look for any clinical features of the systemic disease. So why it has got a diagnostic dilemma is because it can present in a very like fundus picture. So as you can see from this picture, it can present with either mild features of vitritis, disc edema mimicking that of NAION, or even bilateral. It is usually very rare, and it is usually unilateral presentation. Very rarely it can present maybe bilateral, and then you should look for like differentials like malignant hypertension, etc. So the usual presentation might have this vitritis. They present with the disc edema, macular edema, and associated retinal RP changes. The most common feature being the choroidal folds, which you can see here, and the retinal striations. They can have these exudative detachment, which look like sometimes like a PED, and they may diagnose it like a CSCR. They can have massive exudative detachment and a choroidal elevation, which looks like a metastasis or a melanoma, and they can have annular choroidal detachment. So because of this varied presentation, this patients might go undetected in the initial presentation. So what are the differentials? As I mentioned, that it could be tumors or it could be inflammatory. So tumors like melanoma, hemangioma, metastasis, lymphoma, and inflammatory like granuloma, VKH, or central serous chorioretinopathy. So so the main clue in making a correct diagnosis is a multimodal imaging. So the most important being ultrasound B scan. Then OCT, actually of late we see that many of these conditions can have various specific features. And then FFA, ICG, of course, in these conditions, we need to differentiate these conditions. And sometimes we may have to subject the patient for MRI also. So this is a typical classic feature of a posterior scleritis, which the investigation we see usually. So this is the ultrasound B scan. When we do, you can see this is a classical T sign which we come across. And the A scan corresponding to this, you will see that there is a high internal reflectivity. So that is one of the classic features of posterior scleritis, and this classic T sign may not be present in all cases of posterior scleritis. So don't underdiagnose posterior scleritis if you don't see a T sign. Sometimes in a localized nodular posterior scleritis, you might see that the A scan shows an internal hyperreflectivity, but there might be a localized posterior subtenon fluid in that area. So it need not be always an extensive T sign which you come across. And in FFA, you always expect a hot disc in all cases of posterior scleritis. That need not be the case in all the cases. In the first picture, you can see that the disc is not that hyperfluorescent, but in the late phases, you can see that there is the leakage and mild pooling of the dye. So if you don't see a disc leakage, again, don't think that it cannot be a posterior scleritis. So this is a classic one which you see that there is an early hypo in that area, and then the mild slight little disc hyperfluorescence. In the late phases, you can see that there is a leakage and the pooling of these dye. So this is a classic picture which you come across in cases of posterior scleritis. And in OCT, again you can see that there will be an elevation of the choroid, the contour will be elevated, and you might see mild thickening of the RPE, but you can still see the choroidal vasculature structures there, you can see the choriocapillaries, and in retina, actually inner retina may not be showing much of a features, but you can see in the outer retina again hyperreflectivity of the outer retinal layers, and there is a hyperreflectivity of the subretinal fluid, need not be present in all the cases. And there is something called a bacillary layer detachment, which is of late described in cases of inflammatory conditions. Bacillary layer detachment is that you don't, here you can see that RP is there and this is subretinal fluid. In this area, when you see that there is still a layer of the retina there above the RP, and there is fluid collection above there. So still you see that choroidal features in these cases of OCT in posterior scleritis. So here you can nicely see this choroidal folds in there and the disc edema in this case. And the FFA, which shows that early it started mild hyperfluorescence at the disc and mild pinpoint leakage, and here you can see the hot disc. So OCT, again the B scan and the OCT features which I have already described. So the differentials which come across is the choroidal melanoma. You will see in the B scan, the most differentiating feature is the angle kappa in the A scan, where you will see that the internal reflectivity will be low in cases of melanoma. And in OCT, you won't be able to see the posterior extent, and there will be a hyporeflectivity in cases of melanoma. You will see that infiltration of the choriocapillaries with the mass lesion. Another one is the choroidal hemangioma. Again, in chronic cases of hemangioma, you will see that there will features of intraretinal fluid and the subretinal fluid, and FFA will show this diffuse hyperfluorescence. And VKH is another condition. Sometimes it can present unilaterally, which can get confused with the posterior scleritis. But you can see these RP undulation. There will be pachychoroid. You will see vitreous cells, and there is increased choroidal granularity. And ICG and FFA actually helps to clinch the diagnosis, where you see these hypofluorescent areas in the ICG, and in the FFA you can see the disc leakage with hyperfluorescent areas. And another thing which can get confused is the choroidal metastasis. Here you can see this, the RP is usually very irregular and undulated, and the hyperreflective material can be there in the subretinal fluid. So this is a case of CSR, which is subretinal fibrin, which might get confused with the posterior scleritis. But here you can see in the OCT, the RP is straight and it doesn't have much of an undulations, but sometimes they can have a small pigment epithelial detachment. FFA actually helps to clinch the diagnosis, which shows a focal leakage. So when you, once you make a diagnosis of posterior scleritis, it is important to differentiate from the infective pathology. So the patient has to subject to the investigations, and the treatment is usually start with NSAIDs and systemic steroids. So it is very important to differentiate posterior scleritis from its mimicus, so as to, you should pick up the systemic association and any life-threatening conditions like any malignancies or a metastasis. And multimodal imaging is the clue to differentiate these one. And early treatment helps actually to prevent the vision loss. Thank you.
Thank you, Dr. Divya Balakrishnan, for that nice talk.